Good evening. We, the Autism Center of Excellence, are happy to hold the 15th lecture webinar that is part of the series of webinars for Autism Awareness Month, April 2020 via Zoom. Those webinars that are presented by Autism Center of Excellence are aimed to increase awareness about autism spectrum disorder among our community and provide source to service providers. This is Malak Armudi, a senior speech-language pathologist at the Autism Center of Excellence. Today is Thursday, April 16th of 2020, and today Dr. Shuliweeh Alanazi will present a lecture titled The Role of Medication in Autism Spectrum Disorder. Dr. Shuliweeh Alanazi is a child and adolescent psychiatrist at King Khalid University Hospital and King Saud University Medical City. He is also an assistant professor of psychiatry at the University of Ottawa and holds an academic appointment of similar rank at King Saud University. Dr. Alanazi has completed his general psychiatry residency training program at the University of Toronto. Then he joined the subspecialty child and adolescent training program at the University of Ottawa. He also holds a master's degree in medical education from the University of Ottawa. Dr. Alanazi is a subspecialist in child and adolescent psychiatry, having graduated from Royal College Accredited Training Program at the University of Ottawa, followed by certification from the Royal College in Child and Adolescent Psychiatry in 2017. Dr. Alanazi is certified by the American Board of Psychiatry and Neurology, in addition to having a Royal College certification in general psychiatry. He worked as a full-time attending psychiatrist on Children's Hospital of Eastern Ontario Acute Care Mental Health Unit from 2016 till 2018. Dr. Alanazi has published peer-reviewed papers. He has already presented his work at 2 international meetings and in numerous local venues in Ottawa and Toronto. Dr. Alanazi had worked hard on creating a research project from a program development project that is initiated when he joined Children's Hospital of Eastern Ontario. He has already successfully worked in several leadership positions and currently is the head of Academic Quality and Improvement Unit at the College of Medicine at King Saud University. He's also the program director of Child and Adolescent Psychiatry Training Program at King Khalid University Hospital. Welcome, Dr. Shuliweeh.
Bismillah ar-Rahman ar-Rahim. Thank you so much, Ms. Malak, for this introduction that I think I don't deserve. But I have to be honest and start by thanking the Autism Center of Excellence for giving me this wonderful opportunity to meet specialists where we can discuss and have some sort of a venue to exchange ideas, especially for something which is very dear to my heart, which is about the role of medication and how to be used with kids or adolescents or even adults with autism spectrum disorder. I kind of planned this talk today to be some sort of a way to share not only my expertise in using medication, but also the general overview of medication, overview of autism spectrum disorder as a diagnosis, and also what to include in management. And then we're going to focus on some psychopharmacological approaches. So if we review the learning objectives, we're going to go over a quick review of autism spectrum disorder, the prevalence and the etiology. And then we're going to go over some of the clinical presentation and common comorbidities. And the last part, which is the main bulk, is going to be about detailed review of the psychopharmacological approaches in autism spectrum disorder, and also concurrent comorbidities, which is a huge topic. It's going to be extremely difficult to cover within an hour, but I would do my best. And I would encourage you all to just send me an email or send me direct messages on my Twitter account. And I would be very happy to answer those questions. So in terms of disclosures, I need to have special thanks to Dr. Agawal, who helped me prepare this presentation. Most of what you're going to see is based on the most recent clinical guidelines from the American Academy of Pediatrics, which was published in January 2020. So if we start by just giving a general idea, autism spectrum disorder is somehow a bit prevalent compared to other mental disorders. What's interesting is the prevalence is around 1%. And according to CDC and their recent review of the prevalence disorder, at least in the United States, they changed it from 1 in 59 kids to 1 in 54 kids in 2019. I think it's a good opportunity for us to understand that this significant increase could be justifiable by more awareness, more interest from families going through assessments, and most importantly, the significant change in the DSM-5, which happened in 2013, changing the disorder from just being autism disorder to autism spectrum disorder. So by the virtue of changing the diagnostic criteria, what happened here is the threshold to make the diagnosis became less. And now, as clinicians, we became more able and empowered to make the diagnosis. And this is a very important aspect of the management because it used to be an exclusive diagnosis, and still it is. But compared to before, it was extremely difficult to make the diagnosis, and hence suggesting those interventions or recommending some sort of very intensive therapy was extremely difficult. In terms of male to female ratio, we're talking about 4:1. Less than 25% have intellectual disabilities. And as you all know, autism spectrum disorder affects social interactions, mainly plus or minus communication, play, interest, and behavior. When it comes to natural history and impairment, I think what we need to know is that most people with ASD, they do improve with time. And language specifically does improve with time. However, adaptive functioning continue to be poor. And this is something that I want parents to understand, especially when you have time to discuss those issues with them. And I was lucky a few days ago when I presented a topic similar to this to families, to let them know that language would improve, and that's something very good about the disorder, but also to keep in mind that adaptive functioning will continue to be poor unless addressed as part of the overall intervention plan. And I say this because families might get the impression that the kid is improving and the language advances, but this is a misjudgment, because sometimes what they would do is they stop showing up for those appointments, and they might miss that the functioning will continue to be poor, and at the end the kid will have some dependency on family, and then it's going to be very hard to achieve progress in life. Another point about the natural history is that 10% of kids will be free of symptoms by adults. Also, it's important to understand that ASD affects many aspects of child life: emotional, behavioral, medical, and even academic. And the last point here that I also want you to put in perspective is ASD has a huge impact on families. Recent studies show that families, they do spend 1,000 extra hours of care per year, which is an equivalent to half-time job, just caring for one kid. So understanding the huge impact of this illness on families, I think, is extremely important. I like this slide specifically because it emphasizes on the point that no two ASD kids alike. So the way how psychiatrists, and I would assume other professionals working with kids with ASD, they do see kids in domains. So we think about them in terms of their intelligence, in terms of their social interaction, in terms of their communication level, in terms of their behavior, in terms of their sensory, in terms of their motor. And within those domains, there is this spectrum. For example, in intelligence, you might have a kid with severe intellectual disability or profound intellectual disability, but you might see some kids who are gifted. And so if you see that kid on the intelligence, based on intelligence, they might be doing very well if they're gifted. But you have to understand that there are some other domains that needs attention as well. And you need to see where they are. So you might have a gifted child, but he might be passive in terms of social interaction. In terms of communication, he might be somewhere in the middle. But in terms of behavior, he has some intense behavioral issues. And he might have some significant hypersensitivity issues and might be okay in motor. And applying this, some sort of framework, when you see kids, would be very, very helpful to not only to understand them, but also to come up with a very good intervention plan that covers all those domains. I also thought it's a good idea to refresh ourselves in terms of diagnostic criteria. And I have to be honest, I do have a hidden educational agenda, because I wanted to review some and also elaborate on some clinical mistakes that are I've seen or encountered during my clinical experience. So, for example, in terms of criterion A, which is persistent deficits in social communication and social interaction, we need to see this across multiple contexts, and it has to be manifested. And this is something I need you to be careful of. It has to be currently or by history, which means that you might see a kid who might have persistent deficits in social communication, social interaction, but in history. And right now they're doing well, or maybe they don't have those persistent deficits, but having them at one point in their life would make them qualified for this diagnosis. And once you establish this, you have to see if they fit the three types of those social communication deficits. So it has to be deficits in social emotional reciprocity, nonverbal communication, and also understanding, maintaining, or developing relationships. So I think this is very important to keep in mind. And for criterion B, we all know that they do have issues with restricted and repetitive patterns of behavior. And in order to confirm that they do have the criterion B, it has to be 2 out of 4. So the first one is about stereotyped or repetitive motor or speech use. And the second one was insistence on sameness, or being inflexible, or just being religious around routines or behaviors. And number 3 is highly restricted and fixated interest, which has to be abnormal in terms of intensity or focus. And last one is about their sensory input, where they might have hyper or hypo reactivity. And sometimes I get asked, what does this mean, having highly restricted fixated interest? And my usual answer to them is, one of my patients who, she was, I think, 5 years old, and she was fixated on dinosaurs. So everything in her life has to go and be part of dinosaurs. This means that she would only wear pajamas that have dinosaurs, socks, pillow cover, everything. And her family, they were very supportive to the extent that they even put some dinosaur wallpaper everywhere. So the kid would feel enjoyed this kind of interest. We also know that those symptoms have to start in the early developmental period. It has to be impairing their functioning in a significant way. And those changes, they are not better explained by intellectual disability or a global developmental delay, which means that they might have intellectual disability or, or global developmental delay, but the ASD features, or the autism spectrum features, they do extend beyond those disorders. The last point that I wanted to clarify about the severities, about the diagnosis is when you establish those symptoms and you diagnose that kid and you understand that they are different from any other kids that you've seen before, it's extremely important to put a specifier to their disorder. So the way how DSM-5 wants us to make the diagnosis is they want us to think about criterion A and criterion B, the social communication and also the restricted repetitive behavior. And they want us to rank those children or put them on a specifier scale from requiring support to requiring substantial support to requiring very substantial support. And so you might have a kid who has significant social communication, and then you put the specifier that they require substantial support in this domain, but they might have or require only support when it comes to restricted and behavioral criteria. In terms of evaluation, and this is just to give you a hint about how psychiatrists, developmental pediatrician, and I think pediatric neurologists think about ASD. It's very extensive and start from history, where we need to take history about pregnancy, neonatal and developmental history, medical history, family, psychosocial factors, and also intervention history in case if the child has been seen before or went through interventions. And I have to be honest with you, in my clinical experience, I rarely see kids who come in for the first time for an assessment. Most of them, they went through some sort of intervention, or they had at least diagnostic assessment somewhere else, and they come in for a second opinion, or maybe starting or reviewing their intervention plan. And this is very, very helpful. But at the same time, it's time consuming because you need to go back and review all these documents and assess how much intervention they received, the quality of the intervention, and also whether they benefited somehow from those interventions, and then trying to answer some questions why they did benefit from those interventions, and putting those things in, summarizing them in the medical report and building on some sort of achievements that were happened before you get involved. At the same time, part of the evaluation is observing the child, and it has to be through some sort of a play. And this is why when you come into a child psychiatrist's office or a clinician working with kids with ASD, you would find a lot of toys. And this would give us a hint about their imaginative play. Sometimes it gives them room to play and just be themselves, and make a judgment based on their interaction with their parents, with the toys, and also whether they have or have not developed some sort of behavioral issues. At the same time, and also to emphasize that this is a very extensive evaluation, we do take collateral history and also collateral observation of child in social setting. Sometimes we do communicate with school, intervention centers to ask specifically about their behavior and what kind of things they notice in the child. Then we go to the next step, which is physical evaluation. And this includes identifying if they have dysmorphic features, doing some neurological exams, taking some vitals as well, and assessing their vision and hearing. And the last 3 points that I wanted to kind of touch on this slide are the psychological evaluation, the speech, language, and communication assessment, and also the OT evaluation, which are actually done by our colleagues who are part of the intervention or diagnostic team. So psychologists, SLP, OT, and also ABA sometimes, clinicians, they are an important part of the assessment team, and they have to do those issues, those aspects of the assessments, and been shared with the main clinician, which is usually a physician, who would take responsibility based on some sort of legal status we have here in Saudi Arabia, where it's only a physician who make the diagnosis, which is somehow disappointing compared with very developed medical systems in the US and also in Canada, where a psychologist or an ABA therapist at a consultant level can make the diagnosis. So if you do the evaluation, sometimes you might require to do some structured assessments. And I thought maybe it's a good idea to share some screening questions, also some diagnostic tools. So those screening questions like the MCHAT or the SCQ or ABC could be used in family physician setting or maybe pediatrician office in their visit to Well Baby Clinic to help screen kids and identify kids with high risk to be sent for a diagnostic assessment. So this is the initial step. And after that, when a specialist sees them, they might use some diagnostic tools. Having said that, we need to you have to bear in mind that those diagnostic tools, they do not substitute your clinical assessment, because ASD is a clinical diagnosis before everything else. This might help support the diagnosis. And these are the recommendations from American Academy of Child and Adolescent Psychiatrists and also American Academy of Pediatrics. So it's a good idea to, when you are in doubt, or let's say the child does not meet the full criteria, or the case is not straightforward, just feel comfortable to order those diagnostic tools, and this might help you make the diagnosis. So you make the diagnosis, and then you realize that those kids do have a lot of comorbidity. And there is a sentence that I always keep to repeat to myself, which is autism, and also I share this with families. I would say autism come in and bring something else with it. بالعربي التوحد يجي ويجي معه أشياء ثانية. So thinking about this, that comorbidity is the role, is something very, very important. As you can notice that I kind of grouped them in two separate piles here. One about mental health comorbidities, like intellectual disability, ADHD, specific language impairment or disorder, and anxiety, depression, or even having developmental coordination disorder. And also some medical comorbidities like epilepsy, GI problems, sleep and eating problems. So for example, in epilepsy, it's a very higher incidence, where it's 17 to 35%. So after doing this very detailed assessment and evaluation by a group of clinicians, where they assess multiple domains and be able to identify needs for a child, you have to come up with a multimodal treatment plan that tries to encompass all of those needs. And the most important part of having a treatment plan is trying to establish call for educational interventions. And then you have to target some specific symptoms by a structured, evidence-based intervention. And then you have to prioritize those targeted symptoms based on either comorbidity or patient preference. And you have to understand that family preference plays a significant role in this. And I have to be honest with you and say that in my experience, most of parents, they do emphasize on speech interventions more than anything else. But sometimes having a sensory issue, for example, might be the thing that prevents them from sitting still and benefiting from speech assessment. So dealing with other issues, targeting those symptoms and identifying those risks to families is an extremely important job, because it might help you advance some sort of priority for deficits that causing a huge impact or dysfunction, and trying to treat this before moving to the next step. Again, this point here, I just wanted to kind of reemphasize what I've mentioned before, that you have to monitor those multiple domains. You cannot focus on one aspect of the child. You have to include adaptive skills, academic skills, social and communication skills, and even social interaction skills as well. And the last point here is just to think that when you put medication, put a child on a medication, you have to monitor those medication for efficacy and side effect as part of the overall treatment plan. Okay, I put those slides, I think this one and then the one next, just because I don't want you to get out of this lecture thinking that psychiatrists, child psychiatrists, and physicians in general, they only believe in medication. We do believe in treatment, behavioral treatment. So the most evidence is about intensive behavioral intervention, mainly ABA, applied behavioral analysis. But I have to be honest with you again and say that most of the ABA programs offered in Saudi Arabia, unfortunately, they don't reach the merits for what has been recognized as an ABA program. Because it has to be more than 25 hours per week. It has to be adult directed, has to be one-to-one. And most of the programs, unfortunately, they don't have it. So the way how I explain it to a specialist is that they might not have ABA, but they might have what we call it ABA informed approaches or strategies. But calling it ABA and relying on this as a behavioral treatment and neglecting that this is substandard care is not fair. And also this might justify the aggressive or overuse of medication, because those ABA interventions were not optimized, and yet they needed some sort of synergetic effect from using medication. And these are just my clinical observation, and by all means, they are not supported by evidence. In general, most gains happen if the intensive behavioral intervention was very high level. The more the merrier, I think this is the role. And when there is a one-to-one ratio, and if it's more than 2 years, and has to start before the age of 5. So early intervention programs are very important when it comes to treating kids with ASD. Okay, so now we reached the part of the lecture about the use of medication. And I wanted to be very blunt and start with a slide that has too many words, because I wanted to go slowly over those considerations, or what I call them 3 rules. First of all, you need to know there is no medication to help with the core symptoms of ADHD. So there is no medication approved for ASD itself, or ASD symptoms. However, medication might help managing some coexisting behavioral health disorder. So the child might have ADHD, might have mood disorder, might have anxiety disorder. So put in mind that these might be some potential targets. And also, we might use medication for associated behavioral symptoms causing significant impairment, for example, irritability. So accurate diagnosis of coexisting psychiatric condition is the main guide for the therapy. And this goes back to the main point, which is you have to have a very detailed assessment. You have to think about those comorbidities, and then you have to target those comorbidities with a very good intervention plan. Medication also or only could be considered when you rule out any possible medical etiology. And also you have to do some sort of functional behavioral assessment to guide you through the treatment plan. So I think these are the three main roles that all of us should think when you start medication in general with kids with ASD. Risperidone and aripiprazole are the only approved medication for irritability in children. Risperidone for the age of 5 to 16 and aripiprazole for the age of 6 to 17. And also, I think it's very important to refer a patient to a behavioral therapist outside school when you are in doubt about a new change in their behavior, or let's say some sort of irritability. And also only consider medication after a treatable medical condition and behavioral factors assessed. For example, if your family come in and they notice some sort of irritability and changes in behavior, which was some sort of sudden. The first thing that comes to mind is this kid needs some sort of behavioral reassessment. And if the child is there with a school teacher, maybe it's a good idea to refer them to another behavioral therapist who's outside the school system to do a detailed assessment. And in some cases, at least in my clinical practice, there were changes. For example, the teaching assistant was changed, or they introduced some sort of a new curriculum, and now we see some irritability in the child. I think also it's important to include the family and the patient in the shared decision making. At the end of the day, as a clinician, you might prescribe the medication, and it's one step, but it's the family who are struggling with the use of medication, or every single time they use it, especially if it's a daily medication, or if it's a medication that has a route not preferred by the child. For example, medication that requires swallowing and things like that. So now we're going to move on to not only general ideas, but also very specific treatment that could be considered in kids with ADHD, kids with autism spectrum disorder. So for example, if they have ADHD, we need to remind ourselves that, first of all, ADHD scales, no ADHD scales have been validated as of yet for the use of kids with autism spectrum disorder. But also to consider ADHD in the context of language impairment. So sometimes having poor attention and concentration might impact their language acquisition. And I usually think about this in that specific term. And this is also supported by evidence from the American Academy of Pediatrics. Also, it's very important to realize that the medication we use for kids with ASD are the same medication we use for kids who don't have ASD, where they have only ADHD. So they are somehow not different. The last rule, which is should be number 4, not 5, children with ASD may be at a greater risk for adverse effects. And I think this is applicable not only to ADHD medication, but medications in general. Some potential target symptoms domain of pharmacotherapy when you think about ADHD could be hyperactivity and attention by itself, could be repetitive behavior, or could be irritability. Sometimes it could be all of them. Sometimes kids with ADHD do have irritability and aggression as some sort of a presentation or a manifestation. And this is why we do suggest or encourage to use ABC or apparent behavior checklist, which would help not only to identify the hyperactivity and attention repetitive behavior, but also irritability, given that it has an item about self-injury, aggression, mood liability, and tantrums. It's also important to recognize that sometimes kids, they might only have ADHD symptoms by themselves. And this is actually the most common presentation. So 60% of kids with ASD do have ADHD symptoms. However, it's only 40% that meet the full criteria for ADHD. And this is consistent with the most recent meta-analysis published in October 2019, which was an umbrella meta-analysis that reviewed, I think, thousands, maybe hundreds of thousands of kids. The most common comorbidity for kids with ASD was ADHD, with 37%. Also, it's important to realize that methylphenidate, which is a class of medication we use in treating ADHD, is the most commonly prescribed for children and adolescents. However, the other family, which is the, few trials have been used in this patient population. One of the most important studies that I think us as clinicians working with the field of neurodevelopmental pediatrician or pediatrics is the RUB study, where they assessed 72 children with autism disorder or Asperger, which were the kind of the diagnoses we had in the DSM-4. And now we can apply the new criteria in them, and their diagnosis can be autism spectrum disorder and having also ADHD symptoms. So they got 72 children where they have ASD, or what we can call it ASD right now, and also ADHD, and they tried them on methylphenidate. So there was a good response rate of 49%. However, the effect size was ranging between 0.3 and 0.5. And if you compare that number to kids who only have ADHD, pure ADHD with no ASD, the effect size is actually 0.9. So there's a 50% decrease in terms of effect size compared to kids who only have ADHD. An also important thing in this study that they noticed that it's only hyperactivity and impulsivity who improved compared to inattentive symptoms. And this is something that has a huge clinical weight, because family would go back when you start their kid on an ADHD medication. They would say, you know, he improved in terms of hyperactivity or being an active kid, superactive kid, or having impulsivity. However, we didn't notice improvement in attention. And somehow this matches what they found in the study. And the last point goes to what I mentioned before in the general rules of using medication in kids with ASD, that they are more prone to adverse events or side effects. So in this study, 18% they had to drop out during side effects. And most common side effects were similar to other kids, like irritability, insomnia, and appetite. And they also noticed there was a dose dependent, which means you increase the dose, you would see more adverse events. And the more you increase the medication, the more side effects you might encounter. Norepinephrine reuptake inhibitor could be used in ADHD, namely tamoxifen. So this is a study where they recruited 97 youth with ASD and ADHD, and they gave them tamoxifen. I think the trade name in Saudi Arabia is Strattera. So the average dose was given was 1.2 milligram per kg, which is, by the way, the maximum dose. or close to the maximum dose. And they gave it, they compared it to a placebo, and it was an 8-week trial. In terms of their ADHD rating scale points, there was a significant improvement with a p-value of less than 0.001. However, only 21% of patients rated a very much or much improvement. So there was an improvement on the rating scale, but clinically less patient reported a significant improvement. On the other side, 90% of patients in placebo, they do reported the same results. Only one medication stopped tamoxifen due to side effects or events. That was fatigue, compared to the methylphenidate family that we discussed in the last slide. So this might give us a hint that it's more tolerable medication compared to methylphenidate. Also, this is another study where they examined or recruited 128 children with ASD and ADHD. However, here they went all the way to 1.8 milligram, but it was a split dose, and it was a 10-week trial. They did improve in terms of their scale. In this case, the improvement was significant to 47%, compared to 21% that we saw in the last study. What was interesting here is we started to notice also significant improvement on the placebo, which somehow lessened the evidence that we can extrapolate from this specific study. The main side effect here was decreased appetite. The third kind of class of medication that could be used in ADHD or for ADHD with kids with ASD are the guanfacine extended release. In the study, they recruited 62 children with ASD and ADHD symptoms, and the dose was ranging between 1 and 4 milligram, with an average of 3 milligrams for 8 weeks. Those kids, they did improve in terms of their hyperactivity, impulsivity, and inattention, and they reported a 50% much improved significance. So we can infer from this study that guanfacine extended release is a good option when it comes to kids with ASD and ADHD. Sedation, decreased appetite, and dry mouth were the most common side effects reported. So to put things in perspective, I wanted to share this slide with you. So when it comes to targeting hyperactivity, impulsivity, inattention, distractibility, ADHD symptoms in general, you have sex-stimulant medications. You might have tamoxifen, which is an SRI. You might have alpha-2 adrenergic agonist like guanfacine. And there is also an evidence about the use of atypical or second-generation antipsychotics. So these are the kind of the medication that you could use. Just to summarize things for you. However, you need to put in mind that the effectiveness might be impacted when there is a coexisting symptoms. So the effect size is less compared to kids who only have ADHD. So if we take them one by one, methylphenidate can help with irritability. Guanfacine seems to lower the risk and lower the reward. And tamoxifen seems to be the one that is better tolerated. Methylamphetamines or mixed amphetamines do help, and they have similar action to methylphenidate. Omega-3 fatty acid might be helpful. But at the same time, this could be an off-label use. Mixed receptor antagonist could be used for severe impulsivity, especially when there is a huge risk of injury or elopement or just leaving the house. So to conclude, what to do when you have a kid who has ADHD and requires medication. in a stepwise fashion. First of all, you need to implement behavioral approaches. And if the problem persists, you can try medication. You have to start with a low dose of stimulant. This should be your first choice. And then you increase the dose as needed and as tolerated by the patient. Most effective results you would be seen without comorbidity, especially intellectual disability. You should have or should target impulsivity and hyperactivity. And if there are some adverse effects or if the medication it's not effective, I'm talking about methylphenidates here or stimulants, we should consider atomoxetine, especially if there is some social anxiety. And then you can consider alpha-2 agonists, either short or long acting like 1-phenylquinidine. And there is less evidence if you received less than optimal results, or let's say partial response, you might use atypical and psychotic medication because they might help with the hyperactivity. So we concluded what to do with ADHD, and now we're going to review the kind of treatment options. I'm talking here about medication for repetitive behaviors. So when it comes to repetitive behaviors, you have kind of three medications classes. You have the atypical, the second generation antipsychotics like aripiprazole and risperidone. And also you have anticonvulsants like valproic acid and divalproic sodium. And you have SSRI like fluoxetine and fluvoxamine. For the second generation, there are multiple double-blind, placebo-controlled trials documenting improvement on the repetitive behavior. However, it was a short-term treatment. So those studies weren't longitudinal enough to make a judgment for the safety and also the efficacy on long term. The most common adverse events include increased appetite, fatigue, drowsiness, dizziness, and drooling. And this is why it is extremely important to apply monitoring framework to monitor for metabolic disorder. The one that I recommend is are called CHEMISA guidelines. It's the Canadian guidelines to help monitor kids who got placed on antipsychotic medications. And they have an Excel sheet for every single medication that could be used in child and when to do those blood tests and also physical examination, vitals, and etc. Anticonvulsants, on the other hand, they have a modest improvement, especially with divalproic acid, divalproic sodium. There are some reports that topiramate could be added as a second agent with risperidone, and it might give some response. I've noticed that sometimes SSRIs like fluoxetine, fluvoxamine are used in repetitive behavior. However, studies to date did not show any effectiveness of SSRIs in the treatment of repetitive behavior. However, they might help diminish some anxiety symptoms and overall might give us an indication that could be helpful in repetitive behaviors. When it comes to targeting aggression and irritability, I think we have to go over the ROB study, which is a trial done for the use of risperidone in kids with autism. It was 8 weeks, double-blind. There were 2 parallel groups, and they recruited 100 subjects. The mean dose for risperidone was 2.2, which is kind of an intermediate dose. And the range was between 0.5 and 3.5. So 57% they had reported decreased irritability score, and 14% did improve on the placebo arm. And in terms of the response rate, the clinical global impression scale showed a huge improvement based on clinician rating them by themselves. However, there was a significant weight increase in this very short 8 weeks trial where kids, they gained 2.7 kilograms. So this is a huge kind of obstacle to trying risperidone for kids with ASD. This was the 8 week, this was the placebo arm, and this was the risperidone arm. And as we can see, the irritability score has improved with time. And what we can understand from this is that the improvement continued all the way till the 8th week. At the same time, this only can help us anchor evidence at the 8 week point, where we can't appreciate what happens after the 8 weeks. So it's something that you need to put in mind. This is a study about the use of risperidone, aripiprazole, and it was a very interesting methodology where they have a fixed dose of study. It was 8 week double-blind placebo controlled, where they had a large number of kids, like 218, and they had the kind of the full range between 6 and 17. And what they used is they used fixed dose. So they would put them in 4 different arms: an arm on placebo, an arm of patient on only 5 milligram, an arm on 10, an arm of 5, instead of just switching from one dose to another. All aripiprazole arms or doses, they did much better than placebo for irritability. However, there was no significant difference between doses. So kids were on dose 5, 10, or 15, they kind of did the same. The good thing here is weight gain wasn't that significant. It was 1.5 compared to risperidone of 2.7. Common side effects leading to discontinuation were sedation, drooling, tremor, akathisia, and EPS. So these are the three arms where kids here were on 5 milligrams daily for aripiprazole. Here it was 10 and here was 15. And this is the kind of the improvement scale. So most of kids, they had very much improvement, and they it seems like they did the same. So I think what we can understand from the study is it's fine to use low doses of aripiprazole with kids with ASD. You have to justify why you need to give them more than 5 milligrams. There's also another study where they used aripiprazole to help with irritability. In this study, they had 98 kids, and also they did very well. The difference here, they gained more weight compared to the last study. So in general, when you are targeting irritability and severe disruptive behavior, you could use a typical antipsychotic medication, namely aripiprazole and risperidone. And we have multiple studies that could help with this. And also there is evidence that it not only helps with irritability, but also repetitive movements, self-injury, and hyperactivity, at least in those studies targeting irritability. You could also use alpha-2 adrenergic studies. However, they were only small studies. You could use SSRIs, but also it's a small evidence. You could use also anticonvulsant smooth agents that also has small evidence as well. And as you go down the list, you might use some serotonin non-reuptake inhibitors, SNRIs like venlafaxine, but the effect size was very small. And in that study, irritability was not the primary outcome, so it was a secondary outcome. I think we are coming to an end, and I only have a few slides after this. Now we're going to switch gears to talk about use of medication for anxiety and depression. In general, there are no studies on depression specifically targeting kids with major depressive disorder, mood disorder, and autism spectrum disorder. There is no evidence for the SRI that are effective for anxiety in children, but used clinically. This is the kind of the general role. CBT is very effective. However, it has to be modified for ASD. So in terms of medication classes that you could use to target anxiety and depression, you have SSRI, you have alpha-adrenergic, and you have atypical antipsychotics. For the SSRI, most of the trials were about citalopram and buspirone. And also you could use fluvoxamine as well. For the alpha-adrenergic, they showed some evidence for generalized anxiety disorder, separation anxiety, and social phobia. So it could help with anxiety disorders more than mood disorders or depression. And for the atypical or second generation antipsychotics, the role here is could be used when you suspect some sort of mood dysregulation, where you might combine it with a mood stabilizer, or you can use it by themselves. However, again, the evidence for them is very minimal. So I want to stop here. Thank you so much for listening. I'm very happy to answer.